Varicose veins can impair your quality of life. Up to 40% of women and 25% of men suffer from symptoms related to varicose veins. As you begin treatment, it is essential that you understand vein disease and the procedures used to correct it. Veins are responsible for the return of blood from the extremities back to the heart. There are two basic types of veins in our legs. The deep veins, which run next to muscles, carry 90% of all blood return from the legs to the heart. The superficial veins return the remaining 10% of blood from the leg. The superficial veins are often visible, especially when diseased. Malfunctioning superficial veins often cause pain, heaviness, skin changes, and even skin ulcerations. Connecting the deep and the superficial veins are a third type of vein, the perforator veins. Incompetent perforators can also cause significant complications, including skin ulcerations. This condition, known as superficial venous reflux disease, can result in significant disability. Risk factors that can contribute to venous insufficiency include genetics, gender, obesity, age, pregnancy, trauma, and prolonged periods of standing. In healthy veins, one-way valves prevent blood from pooling and flowing backwards. In diseased veins, however, the valves do not close properly and allow blood to pool in the extremity. This pooling of blood, also referred to as reflux, causes pain, heaviness, bulging veins, skin changes, superficial blood clots, and occasionally ulcerations in the leg. If your diseased varicose veins are symptomatic, most insurance companies will cover treatment. Medically significant symptoms include pain, heaviness, superficial blood clots, skin changes, leg swelling, or skin ulceration. Often, insurance companies require the use of conservative measures before they will authorize treatment. Conservative measures may include the use of prescription-strength compression stockings for up to 6 months. Further conservative actions may include leg elevation and the use of mild pain medication. Once these requirements have been met, we will request insurance authorization for the treatment plan. Now let's talk about how to treat your varicose veins. Treatment of your venous insufficiency and varicose veins is done in a stepwise approach. Often, the externally visible veins are the last to be treated. Initially, the primary sources of reflux are addressed before the visible surface veins are treated. The complete course of treatment is usually spread over a period of approximately 4 to 6 months. Patients should expect their legs to possibly look and even feel worse during treatment. Using detailed ultrasound, we carefully evaluate the function of your veins. This information allows us to determine the extent of venous disease and plan the optimal course of therapy for your situation. Typically, combinations of treatments are performed to fully treat venous insufficiency. These possible treatments include endovenous thermal ablation, sclerotherapy, and ambulatory phlebectomy. The treatments either close or eliminate the culprit veins. Following treatment, blood diverts through healthy veins with normally functioning valves. In this way, the circulation in your leg can be improved. Do not be surprised if your treatment plan is later adjusted from what was initially prescribed. Venous anatomy is variable, and as some sources of reflux are treated, additional unexpected sources may become visible on follow-up examination. Understand that treatment of vein disease is an ongoing process. We will work closely with you to manage your vein disease. In complex situations, the entire treatment process can take several months and often requires significant patience on your part. We are available 24 hours a day to answer questions and assist you through the process. Your satisfaction and treatment success is our first priority. Thermal ablation. Oftentimes, a long segment of vein, such as the greater saphenous vein, refluxes. In this case, we can perform a procedure called endovenous thermal ablation. A long tube is inserted into the vein. Energy is applied using laser or radio frequency. The ablation procedure is done in the office and takes approximately 2 hours from start to finish. Initially, you will be given a relaxing medication such as Valium, in addition to a mild anti-inflammatory agent such as ibuprofen. Your leg will then be prepped and draped in a sterile fashion to minimize any risk of infection. A small needle is then inserted, generally just below the knee. Once this needle is inside the vein, a small wire is threaded through the needle. A small tube, called a catheter, is then advanced over the wire in order to accommodate the laser fiber or radiofrequency ablation device. A numbing medication is then injected along the entire length of planned treatment to protect surrounding normal tissue and to minimize discomfort during the ablation procedure. With your leg now numb and the catheter in place, the laser or radiofrequency device is then turned on, and the catheter is slowly pulled back through the vein. The heat from the ablation device thermally injures the lining of the diseased vein, and the vein closes permanently. Once the ablation procedure is finished, a Steri-Strip tape is placed over the entrance incision, and a prescription-strength compression stocking is placed on the leg. You are then released to go home. You can resume most daily activity immediately. We want you up and walking as much as possible. You must wear a prescription-strength compression stocking for 48 hours, night and day, following the procedure. After 48 hours, you may take the stocking off at night, but you must wear the compression stocking the majority of the day for an additional 7 days. At approximately 1 week following the procedure, you will return to the clinic for a follow-up ultrasound to make sure there have been no complications relating to the procedure and to assess treatment efficacy. We also do a 1-month follow-up visit where we again assess for any complications and assess the procedure's success. At this 1-month follow-up visit, we typically determine the possible need for additional treatment. You will experience some pain from the ablation procedure with bruising along the length of the treated vein. This can last for approximately 2 weeks. The pain can be minimized by taking acetaminophen and ibuprofen. If you need something stronger, we may prescribe a different pain medication. There are some potential associated risks with ablation, sclerotherapy, and other vein procedures. Although uncommon, risks include infection, bleeding, deep and superficial vein thrombosis, numbness, blistering, and skin discoloration. Infection risk is minimized by our use of strict sterile technique during ablation and phlebectomy procedures. Persistent bleeding can usually be controlled with approximately 5 minutes of moderate pressure. Your risk of deep venous thrombosis or DVT is less than 1%. The risk is higher if you have a history of previous DVT, are taking oral contraceptives, hormone replacement therapy, or if you have a known clotting disorder. Occasionally, patients may form what we call a knuckle clot, which is a small clot that extends from the recently treated greater saphenous vein and protrudes into the deep vein. Of these knuckle clots, the vast majority of them resolve spontaneously in approximately 4 to 6 weeks. In most cases, there is no need for blood thinners to resolve the clots. Another possible complication from endovenous ablation is persistent numbness or paresthesia. This condition occurs in up to 5 to 7% of patients treated with thermal ablation. In most cases, sensation returns to the affected area within 3 to 6 months. In a small number of cases, this paresthesia can be permanent. The numbness, however, does not interfere with normal activity. Most patients are not particularly bothered by the paresthesia when it occurs. Another complication from thermal ablation is possible skin discoloration with hard lumpiness under the skin. This lumpiness is often the vein itself being turned into scar tissue. Sclerotherapy. Sclerotherapy is another procedure performed for treatment of refluxing varicose veins. Foam sclerotherapy is often performed on veins not visible to the naked eye. It is also performed on veins that are too tortuous or make frequent twists and turns to accept a catheter. Sclerotherapy is the injection of a medication into a vein to close it down. This is also performed as an in-office procedure. Using ultrasound or a special light for guidance, a small needle is inserted into the problematic vein. Once inside the vein, a small amount of the sclerosing medication is then injected. Polidocanol is one of the most common sclerosing medications we use to close veins. Although polidocanol is not currently approved by the Food and Drug Administration, it is known to be very safe and effective. It is one of the most commonly used agents in the United States and throughout the world to close veins. Polidocanol is typically foamed to increase its potency. Once the medication is injected, it fills the space inside the vein, causing irritation and scarring of the vein wall, which ultimately results in vein closure. Sclerotherapy is also performed on the small spider veins of the legs. This procedure is performed by our doctors and registered nurses in office. This is typically cosmetic and generally not covered by insurance. Using a small needle and sclerosant, the tiny veins are injected, which typically eliminates the veins. New spider veins often develop at similar locations. You must wear a prescription-strength compression stocking for 48 hours, night and day, following the procedure. After 48 hours, you may take the stocking off at night, but you must wear the compression stocking the majority of the day for an additional 7 days. Although uncommon, risks include infection, bleeding, deep or superficial vein thrombosis, blistering, skin discoloration, and skin ulceration. Infection risk is minimized by our use of strict sterile technique during ablation and phlebectomy procedures. Persistent bleeding can usually be controlled with approximately 5 minutes of moderate pressure. Your risk of deep venous thrombosis, or DVT, is less than 1%. The risk is higher if you have a history of previous DVT, are taking oral contraceptives, hormone replacement therapy, or if you have a known clotting disorder. Another complication from sclerotherapy is possible skin discoloration with hard lumpiness under the skin. This lumpiness is often the vein itself being turned into scar tissue. The discoloration and the lumpiness resolve usually completely within 9 to 12 months. Another rare complication from sclerotherapy is skin ulceration. Ulceration may occur if the sclerosant agent interacts with tissue outside of the vein. At approximately 1 week following the procedure, you will return to the clinic for a follow-up ultrasound to make sure there have been no complications relating to the procedure and to assess treatment efficacy. We also do a 1-month follow-up visit where we again assess for any complications and assess the procedure success. At this 1-month follow-up visit, we typically determine the possible need for additional treatment. Ambulatory phlebectomy. The third procedure performed in the clinic is ambulatory phlebectomy. Ambulatory phlebectomy is the actual removal of superficial bulging veins. Using a special light or ultrasound, the vein to be removed will be mapped out with a marker. Once the veins are mapped out, your skin will be prepped and draped in sterile fashion. A local anesthetic will then be injected to numb the area surrounding the bulging veins. Once the region is numb, Several small 2 to 3 millimeter incisions will be made along the length of diseased veins. The doctor then inserts a hook-like tool into the incisions, and the vein is simply removed. Upon completion of the procedure, Steri-strips are applied to close the incisions. A medical-grade compression stocking is then placed over the leg, and you will be released to go home. You will experience some bruising and pain following phlebectomy. The pain usually lasts for approximately 1 to 2 weeks. Most patients can use ibuprofen and acetaminophen for pain control and to speed recovery. If the pain is not relieved by ibuprofen or acetaminophen, a prescription for a stronger pain medication may be given. In addition to a pain medication, an antibiotic will be prescribed for approximately 5 to 7 days to reduce the risk of infection. It is important to keep the incisions clean and dry for at least 5 days following the procedure to prevent infection and to speed healing. You will return to the clinic for a 1-month follow-up to re-evaluate the success of the phlebectomy and to determine if any further treatment is warranted. Varicose veins can impair your lifestyle. They can slow you down and cause pain and soreness. With the help of a qualified vein specialist and modern vein disease treatments, you can beat vein disease. We hope this video has helped you to understand varicose veins and the procedures available to treat it. If you have any further questions, please ask your physician.